Hello, welcome back to my YouTube channel. For those who are seeing me for the first time, I would like to introduce myself, Dr. Rocha, specialized in mental health nursing. And recently, I have been making different videos related to different mental health disorders. So, please do subscribe my channel and share to others as it would be useful for them too. Let's not waste time and we'll straight away go into the topic. Today I would like to discuss about PTSD. So, what is PTSD? I think you would have heard of this word. Anyway, we are here to discuss related to that. So, PTSD means post traumatic stress disorder. It's a disorder which occurs after a person facing some traumatic event which causes stress in them. So in PTSD, we are going to discuss about the definition, causes of PTSD, signs and symptoms of PTSD, then diagnostic criteria for it, and medical management and nursing management, psychosocial therapies, which we usually use in post-traumatic stress disorder. So coming to definition part of it. Post-traumatic stress disorder is a psychiatric disorder that may occur in people who have experienced or witnessed a traumatic event, series of events, or set of circumstances. So in this, an individual may experience that this particular traumatic event to which they are exposed to as harmful for them physically, mentally, and they consider that as life threatening, and this event may affect their mental, physical, social, and spiritual well being. So, PTSD definition is that here it occurs in person who have experienced trauma, and this trauma is perceived by the person as harmful and life-threatening physically, mentally, and it will affect their occupational functioning, social functioning, and spiritual well-being. Different types of traumas can be wars, then we have natural disasters, and we have sexual abuses or some violences against persons, and we have crashes, rapes, kidnapping, assaults. So the trauma can be among all these events or anything in that person's life which he or she considers that to be traumatic. So coming to risk factors for PTSD, who is at more risk, male or female? So according to the records, we say women are at greater risk than compared to that of males, and traumatic experiences which have occurred during their early life, like assaults, abuses, physical or sexual abuses, then family history of PTSD or depression, history of physical or sexual abuse, substance abuse, depression and anxiety or any other mental illnesses, person facing high level of stress in everyday life. Long-term stress faced in a person's life, they can consider that to be trauma, which leads them into stress disorder. Lack of support after trauma, coping skills, lack of coping skills. So when we say lack of support, support systems can be of friends, relatives, family members, religious groups, etc. Coming to signs and symptoms of PTSD. Some of the signs include easily distracted, inattentive during conversations, forgetting things easily, distracted themselves, avoiding places and people where or activities which cause them some stress in them, and exhibiting unsteady or unwanted emotional states, especially negative emotional states, isolating themselves from friends, loved ones, etc., irritability and anger outbursts, obviously without no cause. Being jumpy and reactive to loud noises or certain situations, appearing tired or sleep deprived. So, why sleep deprived? Because they cannot sleep. If they sleep, they will get nightmares. So, they will be thinking, recurring thoughts will be coming related to the traumatic event which causes emotional disturbance in them, and they will not sleep. Coming to symptoms of PTSD, intrusive thoughts. So when we say intrusive thoughts, these thoughts are not voluntary. They don't initiate, but still then, like obsessions, like how we say repeated unwanted thought, the same thing. The traumatic event, what has occurred in that person, they keeps coming to that person's mind again and again. Then they will have nightmares and flashbacks, as we said. The next one is hypervigilance. Hypervigilance usually occurs with the perceived threat that they will be attacked again, or they will land up into the traumatic event again, trying to safeguard themselves always, and seeing that they are safe, they try to observe the surrounding areas or environment again and again. So that's what we say hypervigilant vigilance. Anxiety and depression is present in these persons. Difficulty sleeping and concentrating, already said. And because of this trauma, the person can end up using some substances or doing some self-destructive behaviors as well. Coming to other signs and symptoms, as already discussed, anger and irritability is there. Then guilt, shame, or self-blame. When we say shame or self-blame, like for example, if we take the recent incidences which have occurred in AP states, Andhra Pradesh and Telangana, then some parts of north also, we had a natural disaster like heavy rainfall due to cyclones and flooded. And during these floods, if we just look into the scenarios, different types of scenarios, we see how on our YouTube different recording shows that people have suffered with lack of food, shelter, and they have been suffering, having babies with themselves, and they have been in hunger, not able to sleep, power cut, etc., etc. This instance will be perceived by them as a traumatic event, biggest traumatic event in their life. So it might take months for them to recover from this event. There are chances of these people landing up into stress disorder. And we see a son just telling, I lost my parents in front of my eyes. So he will develop a feeling of guilt. He will think, if I would have done something else, maybe I would have saved my parents. That's how it is. When an incident happened in front of our eyes, maybe bomb blast, where people died and some are just surviving and some having fractures, bloodshed everywhere, might think maybe I would have done something. So they try to blame themselves. This is how it happens in traumatic events. So other signs and symptoms include substance abuse, feelings of mistrust, depression and hopelessness is present in them, suicidal thoughts and feelings, and feelings alienated and alone. Like, no, they feel that they are alone, isolated, and they don't have anyone. And presence of aches and pains also might be seen. Coming to PTSD symptoms in children and adolescents, so apart from the signs and symptoms which are present in adults, children or adolescents, they feel that they are separated from the parents. That is one thing. Then they really do not have the memory of the event, but they will have some nightmares, anxieties, phobias, sleep problems. They might not exactly tell what is the cause of it. Then they lose their memory, whatever they had some training, maybe toilet training and all, because of this trauma, they lose it. And they try to show out what they are going through in through telling by telling stories or drawing pictures. In their play they will try to express, and without no cause they will also complain that they're having aches and pains, they will have irritability, aggression. Then these are all certain signs and symptoms which we see in persons suffering with post-traumatic stress disorders. Now there is a screening tool for patients to just find out whether they are suffering with PTSD. So the tool named as dreams here. Each word has like a meaning. D for detachment, R for re-experiencing the event again and again, the traumatic event. Event had emotional effects. Then avoidance of situations or an event which has occurred. The places are mostly avoided, and at least these are present in the person for a month in duration. Definitely it takes a month. And sympathetic hyperactivity or hypervigilance is present in the person as described in signs and symptoms. Now coming to DSM-5 criteria for PTSD, we have criteria from A to F. So under each criteria, if a person fulfills the requirements of this, then he may be diagnosed with PTSD. Now coming to criteria A, it is about stressor. At least one stressor should be present. That means the person was exposed to death or threatened death or any injury or any sexual abuse or any other thing, either directly or indirectly, or witnessed or maybe heard when somebody else is talking. Either it may be from the close friend or it might be indirect exposure to the details of the trauma, usually in course of professionals. It's related to us. We medical persons, we come across sexual assaults or victims who have been sexually assaulted, raped. So when we hear their stories, that can indirectly cause a trauma in us. So among these, at least one should be present. That's what it says. Next, coming to criterion B, intrusion symptoms. At least one is required from this. So coming to intrusion symptoms, either they may be unwanted upsetting memories, nightmares, flashbacks, emotional distress after the exposure to traumatic reminders, physical reactivity again after exposure to traumatic reminders. Coming to criterion C, avoidance. One is required. Trauma related to thoughts or feelings, trauma related to external reminders. So whenever we are using these reminders, that means the event, when that same thing is discussed again, we say reminder. So this is another criterion. Next, coming to criterion D, we have negative alterations in cognitions of mood. That is always, mostly it is negative thoughts and negative feelings that began or worsened after the trauma. Inability to recall is one feature. Overly negative thoughts and assumptions, blaming themselves, negative effect, decreased interest in activities, feeling isolated, difficulty experiencing positive effect. Now coming to criterion E, alterations in arousal and reactivity. So under this criteria, we have aggression, irritability, risky or self-destructive behavior, hypervigilance, heightened startle reaction. When we say startle reaction, when we see something which is really dangerous, threatful and harmful, we try to just open our eyes wide, So startle reactions. And next one is difficulty concentrating and difficulty sleeping also. Coming to criterion F, duration is the main important factor here. These symptoms should last for more than 1 month. Why we need to understand this? Because whenever a trauma occurs in a person's life, it usually takes some time for a person to cope up with that situation, isn't it? So normally a person can cope within a month, 3 weeks, with the coping mechanisms, whatever he has to cope up with the situation and move ahead with his life. But still, after a month, the person is having the same stress in him and anxiety in him, and this anxiety is present continuously. There are nightmares and flashbacks for more than a month, and the person is not able to overcome the situation, and he's facing stress which is affecting his normal routine life, as well as his occupational functioning, as well as social functioning. Then we consider that to be PTSD. Now, coming to other criterions like G, functional significance is required. That is, symptoms create distress and functional impairment. That's what I said. Then criterion H, it is an exclusion criteria. That means symptoms should not be caused due to medication, substance abuse, or other illness. Coming to two specifications, actually these specifications are dissociative specifications, and I am supposed to discuss these two in dissociative disorders, but since these are more relevant to PTSDs, I thought I will discuss here now. One is depersonalization. When we say depersonalization, experience of being an outsider, outside observer, or detached from oneself, means here a person thinks about himself, this is not real, I'm in dream, this didn't happen to me, is the thought here. Depersonalization. Just imagine a situation in front of your eyes where you have gone to a beautiful area, maybe park, where so many members, colleagues, all of them are present, and suddenly something bad like bomb blast or something happens and the whole area is disrupted. You see bloodshed everywhere and you too have got injured, and after some time you might think this is not real because this didn't happen to me, because your mind doesn't accept whatever has happened. So it is not associating with the reality. That's where you feel this is not me, this didn't happen to me, and this is not real, maybe I'm dreaming like that. That is called as depersonalization. Then coming to derealization, it is experience of unreality. You think that the surrounding is not real, things are not real. One thing is, in depersonalization, you feel that what has happened to you is not real and this is not you. And in derealization, you feel that the surroundings are not real. So another, apart from this, we have like delayed specification. When we say delayed specification, like for this signs and symptoms of PTSD to be present, it almost takes more than a month, like until 6 months after the trauma, maybe the person will try to show out the stress disorder, signs and symptoms of PTSD. So that is called as delayed specification. So this is about DSM-5 criteria for PTSD. I hope you have got a clear picture of it. Coming to treatment of PTSDs. So one aspect is psychopharmacology, where we treat the person with antidepressants, and under antidepressants criteria, we are going to treat them with SSRIs. You know, SSRIs means selective serotonin reuptake inhibitors. We have discussed in detail related to SSRIs while discussing about antidepressants. So what is the action of these drugs? They try to increase the level of serotonin at the synapse. So under this category we have sertraline and fluoxetine. Next we have another classification of drugs, benzodiazepines. These are otherwise dealt in anti-anxiety drugs. You can go to my other video, anti-anxiety drugs in anxiety disorders. So benzodiazepines, we have lorazepam, diazepam, oxazepam, clonazepam, etc. All zepams will come under this benzodiazepines. We have chlorodiazepoxide also, which is mentioned. So these drugs are tranquilizers. They remove the anxiety or stress in a person. They just keep the person's mind calm. Next, coming to different types of psychotherapies, we have supportive psychotherapy, okay, crisis management and stress management. Crisis management and stress management, I will do a separate video later on. But anyway, coming to this psychosocial treatment, first one is trauma focused CBT. When we say that word CBT, it means cognitive behavioral therapy, a therapy which is mainly focused on thoughts, feelings, and behaviors of an individual, how we need to change these negative thoughts, negative feelings, and their behaviors. So, here, the mostly this therapy is focused on slowly and gradually exposing the person to their thoughts and feelings related to the trauma or traumatic event, and teaching them by using different like different techniques like relaxation techniques, meditation, identifying what thoughts are upsetting them, and some specific techniques are taught individually as per the person related to what trauma he is suffering. Next, coming to exposure therapy, when we say here, you can see this one related to phobias. We have seen exposure and response prevention therapy. I have described this in detail in my previous video as well. So, coming to exposure therapy, what happens is the person is exposed slowly with the imagery or directly, taking that person to the where the traumatic event has occurred, to the place, and asking the person to just recap the things, at the same time helping him with the coping strategies, asking him to use different techniques like relaxation techniques after returning back to get out of that incidents whatever has occurred, and from the memory what he remembers. Next, cognitive restructuring therapy. Here it involves identifying irrational pattern of thoughts, feelings, behaviors that emerge after traumatic event. So here we say these persons will be having negative perspective or negative view of life. So what we are going to, they will tell like, I am never going to be normal again, I'm going to die, there is nothing, hopelessness will be present. But we make them think in a different way, like, I'll be better, it will just take time, I feel scared but I'm safe. We ask them to repeat these statements so that they can perceive in a different way. That's how it is. The thought pattern of the person, negative thought pattern, or thoughts are identified and they are restructured. The thoughts are restructured. Then another thing is eye movement desensitization and reprocessing. Here the patient is asked to concentrate on an image or an event which he considers as traumatic, and the emotions and thoughts, and the therapist, whoever is dealing with this person, what he does is, in front of that person's eyes, he will try to move his fingers from one side to another side like this, and the person is asked to open his eyes and just imagine an event where the therapist moves his fingers from one edge to another edge of the eyes. So the thoughts or images are disrupted here in front of their eyes, and this is done for 20 seconds, and patient is encouraged to let go of the memories and discuss the emotions what he has experienced during the eye moments, because there is a disruption or continuity in the flow of thoughts is a bit hindered, you can say. This is what, and this process is repeated persistently again and again, and slowly the person will be encouraged on positive thinking, positive emotions, and positive behaviors in future. That's how it is. Next, coming to family therapy, when a trauma is experienced, by an individual. It's better because family is a support system for us. We discuss with the we ask the members to discuss with their families, or gather a family, discuss with the family along with the person who is having PTSD. Let them share their thoughts, and definitely he will get a psychological support. That is one thing. So it's like sharing with the loved ones. They understand your what's your problem, and they encourage you. That's how the relationship can work better. Next, coming to group therapy. Here when we say group therapy, more they people feel more confident, and they will be able to trust others. Why? For example, if you take the same thing, what natural disaster has occurred, like flooding and all, there are several families which suffer with the same event. So what happens is that when the group of people gather there, they do share the incident in their own perspective, own view, and they do explain themselves what they have viewed as traumatic, which might be lighter for the other person. That's how whatever feeling they are having, anxiety which what they are having, guilt feelings what they are having, they are expressed, shared, and later on they get support. They feel it's not me alone in this world who is suffering, there is another person still, and they try to comfort each other. That's how it works out, group psychotherapy. And definitely in group psychotherapy there will be a therapist who will try to guide the conversations, whatever is going on in between the group, and he will teach a positive way of solving the things what they are going through, and develop a positive perspective towards life. That's how it helps. Now coming to nursing diagnosis, this is very important for us, isn't it? Under nursing assessment, we are going to see through all the scenario, case information, going to do mental status examination, then identify the signs and symptoms and the diagnostic criteria. Then according to the priority, we frame the nursing diagnosis. So you all know related to that. So, and we have seen so many nursing managements, isn't it? So for here, particular for PTSD, we have post-trauma syndrome related to distressing event considered to be outside the range of usual experience. Post-trauma syndrome related to distressing event. Distressing event might be traumatic event. This is considered as traumatic by the person. So our nursing interventions usually starts with first one, explain all aspects of care and gain consent. Then assess the mental status examination for perception, thought, mood, because these are affected. Accept the client, try to establish rapport with the client. Then offer time for the client to verbalize his feelings, thoughts, and stay with the client during the flashbacks. Discuss with the family members regarding the coping strategies, regarding the patient also regarding the coping strategies, relaxation techniques, then meditation. Then involve the person in some outlet activities where he can just vent out his frustration, anger, then his aggression, whatever he has in him. Then sit with the person, provide psychological support, ask him to comprehend the trauma what he has, ask him to express himself, okay, his personal experience, how he has felt, administer the medications, observe for effects and side effects, refer to psychotherapist for CBT, or refer for group therapy as needed. Then ask the person if he feels like anything like sharing, downhearted, sad, anything like that, self-destructive behaviors are present, means see that the environment is safe. Then document all the care given for the patient. That's how we usually just implement these things. Next, coming to dysfunctional grieving related to loss of self or as perceived prior to the trauma. Dysfunctional, grieving, when we say internal grief is there, it's not that very obvious that the person will cry in front of you. The grief will be there inside. Either it may be that some trauma has occurred to him or to the family members or the loved ones. So here also the same thing, like nursing interventions, we need to explain all aspects of care to the person and gain consent. Next one is like you assess the mental status examination of the patient for mood, thought, acknowledge the feelings of guilt or self-blame, assess the client's stage of grief process. You know the stages of grief process according to Kubler-Ross. We have denial, anger, bargaining, depression, and the last one is acceptance. So at what stage the person is fixed, we need to assess that. Then assess the impact of trauma on ability to resume to ADLs, activities of daily living. Assess for self-destructive behaviors that we know. I said, like already in my previous nursing diagnosis, I said if the person is having any self-destructive behavior or ideas, you have to consider it as a harm. You have to take it serious and provide harm-free environment, remove sharp objects, keep the environment calm. Then assess for maladaptive coping like substance abuses and see that the person is safe from all those. Then refer for any psychotherapist if needed, administer the prescribed medications. Okay, these are all certain things. And apart from this also, we have other nursing diagnoses which I have discussed priorly in other videos, like we said poor sleep. Sleeping hours is less because they are having flashbacks and nightmares, they cannot sleep. For that you have to take care of the person, educate the person about importance of sleep, hygiene, provide distraction free environment, help the person to have a warm shower bath before sleeping, give warm milk before sleeping, and put on dim light, etc. So all these can be done for sleep problems. Then we have nutritional problems, then personal hygiene. You have to consider all these things and educate the person. So we have another thing like ineffective family coping. So here family members need to be involved in that also. So as per the necessity, as per the the nursing diagnosis, what you frame, you have to plan on the interventions. Then after that we come for the evaluation, whether the symptoms have reduced or not, whether anxiety has reduced, stress has reduced, whether sleep pattern has improved or not. Then dysfunctional grieving should be reduced. All these things should be assessed. So this is all about post-traumatic stress disorder. I hope you got a clear picture of this. And if you have anything, just leave in a comment box. I will go through definitely, and I will try to rectify the things for you. And before I could end this, please do share and subscribe. Don't forget. Sharing to others is very important because it might be helpful for others too. And we'll be back soon with another video. Till then, bye bye. Thank you all very much for listening to me. Thank you.